And so moving on, do you want to tell us about the other?
So the one on top is the focus device, which is a true shockwave. So the energy levels are, in terms of touching on the skin, about 10 times more. But by the point with this is that the energy will come out of the end here, and we have these little adapters that change the depth.
Sorry, 10 times more
energy
of the mechanical.
Than that one.
10 times more?
Yeah.
Wow.
Well, in fact, significantly more than that, actually. So what happens with this one, the radial device will send its energy out and then it disperses like that. So by the time you've gone 2 or 3 centimeters in, for the energy where you want it, lots of it's gone over there and over there. So the amount of energy in the tissue breaks down quite a lot.
Right.
So this one is a constant beam of sound wave.
Right.
That most of the energy will then what we cause a cavitation. So the sound wave, like a bubble bursting, is about a centimeter off the end of here.
Right, so you'd actually see that depression on the skin?
No, you wouldn't see that because it happens inside.
Right, okay.
The whole point of this is that you don't, if you can imagine designing one of these, you'd say, well, I don't want to waste any energy on the skin or the fat. That's not where I need it. I need the energy inside where the tissue is, yeah?
Right.
And this one does that. This one does not give you any energy at the skin surface. It gives you all the energy inside. Right. And you can calibrate it to go as deep as up to 12 centimeters. So a lot deeper and no loss of energy. I'm trying to think of an advert.
Quite strong,
no loss of energy. It's like a Dyson.
Okay.
There you go.
Sorry, 12 centimeters.
I've got to remember that one.
12 centimeters is
Yeah, I mean, I treat the posterior hip and behind the hip.
Right.
So, for instance, the posterior capsule, maybe piriformis.
Right, excuse me.
Inside line, that's a long way in. Some people with, depending on their habitus, if I can politely say that, you need 6, 7 centimeters, 8 centimeters in through fat to get to where you need to get.
Right.
And if I took that off and put that against the skin, now we're talking out here as depth.
Right.
And no loss of energy on the way in. And these, like a hamstring tendon, is a big old tendon. And if they're really chronic, they're really horrible conditions of proximal hamstring tendinopathy. And you can get in there with this.
Okay, and so actually someone's asked this question, right? Mayuri has said, are there any type of insertions contraindicated?
Insertions of tendons, I assume she means.
I presume so, yeah.
No, not contraindications. The only contraindications are those 3 things I said earlier.
Right. I mean, okay, so the risk factor, going back to contraindications, something deeper than you can palpate, see.
Yeah, absolutely.
But then, so there is that little risk factor if you haven't spotted, let's say someone had multiple myeloma and didn't know it.
Oh, blimey, yeah.
Well, I'm just saying that that could be the case. It happens.
Yeah, they can happen. Yes.
Okay, so just to broaden the risk, one has to look at the downside as well as the up.
Yep.
And obviously that would be a factor.
Yep.
So certainly know, seeing people in practice, those things do come up.
They do.
So Anthony asks, is it okay to treat around a trochanteric bursitis?
Okay, so we're in the realms of heel spurs again. So we think that only about somewhere in the single figures of lateral hip pain would have any bursa involved at all. And a really good study done by the Society for Orthopedic Surgeons that just deal with hips, 2019, and I spoke to those guys that did the study, and we know that we treat bursas all the time with Shockwave, and they seemingly don't react badly at all. But most GTPS is just a tendon. We need to move away from trochanteric bursitis. It's still used in GP practices, but a trochanteric bursitis, when you see one, you literally see it. It's literally that big. So if it's a tiny bit of fluid that you see on an ultrasound scan, we think it's not clinically relevant.
What about infrapatellar bursitis?
Oh, sorry, I thought you were talking about GTPS.
Well, we were, but there's other bursitis.
No, around other bursitis
as well, just
around the knee. Yeah, they're obvious, but they can happen independently of the tendon problem. There are some joints, like shoulders. It's very difficult to get a subacromial bursitis without a supraspinatus tendinopathy. It's almost impossible. They go together. So we've sort of lumped those together as subacromial pain syndrome now. GTPS is called that because it's likely to be the tendon plus a little bit of the bursa plus the periosteum. We're not, but mostly it's the tendon. But it doesn't dissuade you from using Shockwave on it.
And what about using the Shockwave directly on muscular tissue that's contracted?
That's actually, the radial would be good for that. That's where you in an advanced setting like, mine, where I treat it a lot and see lots of those conditions, you do the radial with the muscular stuff because it treats a broad area. And then you get this out and you use it on the tendon, like the insertion of the Achilles.
So you're using a bit of a combination of the two?
You do. And then I use my hands. And then I use the graded loading program. It's not a standalone. It's not just, I'm a Shockwave guru. I'm just a tendon guy that uses these tools to get where I need to get with chronic stuff. Okay,
and Hussein Jiwa, I think that's how you pronounce the name, would Shockwave aggravate hairline fractures? Let's say there's a little hairline thing, or even a shock, or even a, what's the word? Forgot the word. So one of those hidden fractures you don't know you've even got.
Yeah, or like a stress fracture.
Stress fracture. That's the word.
Back in the day where we used to use a tuning fork to vibrate the bony ends, you would get that with that. So that's how, you'd get an immediate pain response. Quite a good diagnostic tool. There are actually there's a couple of orthopedic surgeons I know in Germany, one's been on my podcast, that uses it as a bit of a diagnostic tool for that.
So would that be something to avoid?
No, it's actually there's really compelling evidence for non-union fractures, treating stress fractures and treating non-union fractures with Shockwave. Brilliant evidence. High level, level 1 stuff. And the reason for that is the mechanotransduction. So if you're not able to weight bear through your tibia because you've got this non-union fracture, you're not creating osteogenesis. You're not creating those piezoelectric forces through the leg. You're literally using sound waves to put in what you're missing. So I've treated 3 or 4 non-union tibias, and they were all timetabled to go into for revision surgery, and all of them didn't.
Okay.
I got the surgeon's permission, and always got that, but
How did he obviously gave permission, but how did he connect to the process and what you were offering?
He didn't really. There is a device called an Exogen device, which is a wearable ultrasound device. Bupa approved, NICE approved, as long as you got non-union after 9 months. And I just said to him, look, it's sound waves. It's all the same. But mine is really high energy, can really help bring this along. And he went, yeah, fine, do it. But I thought it was ethical to ask his permission, and the patient, obviously. And they all didn't have to go into surgery. It's brilliant for that.
Okay, I've got another question from Kathy Mee. Do you perform a diagnostic ultrasound prior to Shockwave or work on clinical judgment alone? And apologising if this is already covered, but I don't think quite that way.
I look, the luxury of now being qualified in that, I do use it a lot. Yeah.
Did you qualify in that first?
No, I've only qualified in that this last year.
Okay.
So that was a long haul. You've got a postgraduate in that, so it's difficult, but it's well worth doing. It's because it fits with what I do as a practice. But yeah, the clinical judgment for nearly all cases is absolutely fine. The occasions where I do see a bursa in the absence of any tendon, so the retrocalcaneal bursa of the heel, that's quite common. And you damn well think it's an Achilles tendonitis or an Achilles tendon problem. It isn't. The tendon's fine.
So the diagnostics, coming into diagnostics, if you're not evaluating it, I'll say osteopathic, but if you're not evaluating it fully or adequately with hands-on or with evaluations of other sorts, the ultrasound is almost key.
Yeah, well, I wouldn't say it's key. It's just if you see as many as I do, if you see not as many, it's just numbers. I'm going to pick out 1 or 2 a month where I scan it and go, oh, that's not what I thought. And Shockwave's therefore a waste of the patient's money. But I'm never getting them out. It's not going to cause any problems, even if it was just a bursa. It'd just be a waste of my time and their money, and I don't want to do that.
Wouldn't make it worse, wouldn't make it better.
No, just wouldn't do anything.
Okay, and someone asked here, are there any novel uses? I think we've covered a few. Novel uses of Shockwave therapy.
Novel would be novel would still be probably non-union fractures, even though the evidence is really good. But we just don't see enough of them in practice in the world in which we
wouldn't be advertising, come in with your non-union fracture and we'll sort it out.
No. That would be a bit ridiculous in a way. That's why I partnered up with a surgeon to agree it, because they were the primary carers in that. There is lots of work going on now with chronic pelvic pain, prostatitis. There's a massive study at London Bridge on post-prostatectomy. So it's one of its things is angiogenesis with focus shockwave, the expensive one, promoting blood flow into the penis.
So we're going to come on to that when we sit down again, I think. We'll leave that just for a minute. But erectile dysfunction, I know, is something we might chat about.
That would be one of the novel ones.
That would be one of the novel ones. So we'll talk about that in a little bit. But going to this sort of boosting blood flow, is it also about boosting blood vessel proliferation, new blood vessels?
Yeah, that would be it. So angiogenesis, new blood vessels growing into the tissues or around the tissues in the case of tendon disorders.
Right.
So we think it probably has some elementary effect on stem cells and proliferating the right kind of tissues. So stem cell will become a tendon if you put Shockwave over the tendon. It will become bone if you put it over the bone. So it seems to just promote wherever you put it. It's boom, done. So in cardiology, they put it over the vessels of the heart, but they also use it that's high energy, they use it to destruct the calcium layers within the arteries before you go in and stent. And the outcomes are brilliant for stents then.
But with the surgeon on hand?
It's all surgeon stuff. We're talking £1 million version of this is used to soften up the vessel walls to make the stent go in better.
Right.
So in cardiology, it's a big new thing for that.
But much higher energy even than this?
Much higher energy than this,
Okay.
And more targeted, as you'd imagine. You want it to be targeted.
Well, I think you do, So do you want to demonstrate a little more with the other heads, the other version?
So this is the one, this focus. This is proper Shockwave, much higher energy. So if you think about what that felt like on your arm.
Yes.
Sorry.
No, I'm getting a little nervous.
You've got a wet shirt.
Yeah, don't worry.
This is, you'll feel it, but not nearly in the same way. So if we pop that on and just sit it there for a while. and move it up. So this would be where you'd be treating a tennis elbow at the top, and it takes a bit of time to build almost. And you'll start to get a sense of what most people would describe as a sort of, almost like a toothache in the outer bit of the elbow.
It feels like you're pressing harder.
That's right.
But you're
So
not.
yeah, it's a pressure sensation. I'm not pressing at all. And you know, that there, the energy that I've just put into your elbow would be magnificently more than the radial pressure wave that we did put on there. That feels like it's...
Well, that felt a lot more uncomfortable, to be fair.
So for insertional Achilles tendon problems, which are notoriously painful, they wouldn't like you much for treating them with a radial device. So it's a nice way of getting energy in deeper and making the treatment more comfortable for the patient.